take time on a Saturday night and joined us. We welcome you to the very first webinar of 2025 hosted by ISPD. And it is going to be on pediatric vascular dermatology. So to kickstart the program, I would like to invite our beloved President, Dr. Jaika Thomas, sir, to introduce and say a few words.
Thank you very much, Dr. Sahana. Good evening, everybody. It's indeed a pleasure to meet every one of you for the beginning of this year, because we've been doing a lot of activities last year, and this is the first meeting this year. I welcome all of you, particularly the two pillars of the ISPD Academy, Dr. Ram Gulati and Dr. Rahul Mahajan. And you will see that from the program and the agenda, Rahul Mahajan is going to be one of the speakers and also going to be one of the panelists. So that gives a lot of mileage for Rahul to share with us all the knowledge that he has. And the topic, as you know, is about hemangioma. One person is going to talk about the medical management, namely Rahul, whereas Dr. Rajiv Ray is going to talk to us on the surgical management, which means, obviously, my dear friends, that we have come to management. We're finished with etiology, etiolopathology, and all that, no clinical features, which also means that the moment we talk about hemangioma, one also thinks about cutaneous and vascular malformations. The vascular malformation, first thing is the basics is to differentiate hemangioma from a vascular malformation, which becomes very, very important. Other than sure, Dr. Rajiv will be telling in his discussion, management will become futile. The method of management will become futile unless and until we differentiate these two conditions. We have vascular malformations and we have vascular tumors, one which is proliferative, one which is just dilatative. So with that few words, of course, I also invite all of you present here. The wonderful program, the ISPD, is a standard by itself, and it's got a brand by itself, in spite of other associations and other societies trying to work in pediatric dermatology. This has stood the test of time, and it's come up to this level. I won't take away much time because there's so much of interesting matter waiting for us. So before we go to the first speaker, namely Rahul Mahajan, I'll request our one pillar of the ISPD Academy Committee, Dr. Ram Gulati, to just say a few words. Dr. Ram, the stage is yours.
Many thanks, Jaika sir, and very good evening to everybody. I think as a convener of the ISPD Academy with Dr. Rahul Mahajan as the coordinator and a host of members of the academy, I think our aim as such is to enhance the academic pursuits in the field of pediatric dermatology so that we can enhance the studies and various endeavors which can get focused on pediatric dermatology topics. I mean, the academy as such, if you see, that was formulated at the end of 2024. And it is an academic initiative of ISPD per se, and along with the yearly conference that we want to do. The aim is to have periodic webinars focused on very important and relevant topics. For example, we had the pediatric infectious diseases one in November last year, and with the first one in 2025 on the vascular dermatology today. So the idea is also to enhance the research studies, including multicentric studies, so that we can get more Indian data that can go towards formulating recommendations and guidelines. So I think with these few, I would say that overall, our aim is to enhance the academic pursuits in the field of pediatric dermatology. That's what I would like to say, Dr. Jacob. Thank you very much.
Yeah. Thank you, Dr. Jaika, sir, and Dr. Ram, sir. So let's directly jump into the first speaker of the day. All of us know Dr. Rahul Mahajan. He's the additional professor at PGI Chandigarh. He's got more than 200 publications, and he's also the chairperson of the ISPD Academy. And today, sir will be talking about updates in the management of infantile hemangiomas. So over to you, sir.
Thank you, Sahana. So is my screen visible?
Yes, sir.
Am I audible? So thank you, JT sir, and thank you, Ram, and thank you, Sahana, for the nice introduction. So what I shall be speaking on is on the management of infantile hemangioma. So I shall basically focus my talk on the clinical approach towards the diagnosis, investigational aspect, and the treatment of infantile hemangioma, along with some of our own experiences at PGI Chandigarh. So this is the ISWA classification of various vascular anomalies. This is the updated classification, and I think all the residents should go through it. So infantile hemangiomas per se, they are the most common of the vascular tumors in this age group, in the infancy. And it's good that they are benign, but then we don't see a lot of other malignant ones or the locally aggressive ones, but we should be aware of these entities also, like a possiform hemangioendothelioma or other malignant ones like angiosarcoma. These are uncommon and rare in pediatric age group and especially in infancy. But as was being mentioned earlier also, that we need to differentiate the benign vascular tumors, that is infantile hemangioma, from the other vascular tumors as well as the vascular malformations. We'll come to that in the subsequent slides also. So coming to risk factors for infantile hemangioma, the most commonly cited one is the female gender. And there are studies which have suggested that the estrogen receptors are a lot more expressed in infantile hemangiomas, and perhaps that may be one of the reasons for female preponderance, but that it has been seen across different races and different continents also, that females are predisposed in a ratio of almost 3:1 towards development of infantile hemangioma compared to males. Then prematurity is another big factor, and infant newborns weighing less than 1200 grams, they have a very high prevalence of infantile hemangioma. The prevalence tends to increase significantly by almost 40% for every 500 degrees in the birth weight. In very low birth weight infants and extremely low birth weight infants, the prevalence of infantile hemangioma is even higher. Then multiple gestational pregnancy, advanced maternal age, placenta previa or preeclampsia, and use of in vitro fertilization techniques. Again, these have all these any situation which predisposes to hypoxia in utero predisposes to infantile hemangioma. And in fact, there are studies from recently from China which also cited maternal anemia as one of the risk factors, because even maternal anemia can predispose to fetal hypoxia and perhaps increase the risk of infantile hemangioma. And some of these factors are in fact risk factors for Faces syndrome also. Although female gender is even more highlighted in Faces syndrome. Again, the reasons are not fully clear, but female gender is a lot more pronounced. Female preponderance is a lot more pronounced in occurrence of Faces syndrome. So I'll spend half a minute on this because we'll be concentrating more on management and less on pathogenesis. But this helps us to understand what are we dealing with, and maybe some of the uh, medications also. So, as I said, anything that predisposes to hypoxia increases the chances of hemangioma. So it is because hypoxia leads to release in the hypoxia inducible factor 1A, and this in turn leads to upregulation of GLUT1, VEGF, and IGF. All these factors in turn lead to vasculogenesis and angiogenesis and endothelial cell proliferation. And also, this hypoxic insult also leads to high levels of renin, which in turn causes the upregulation of angiotensin 2. And this renin angiotensin aldosterone mechanism, as we understand today, it again is important in upregulation of angiogenesis and vasculogenesis and endothelial dysfunction, and then predisposes to infantile hemangioma. This theory about the placental mesenchymal cells embolization and the mosaic occurrence, this was considered in the past, but now it is given less importance, with more prominence of hypoxia as the central feature in occurrence of infantile hemangioma. With this, we go to the management part. So as I said, management involves not just the treatment, it involves a proper clinical evaluation of the child and investigation, and then assessing the treatment. So once we see a child with infantile hemangioma, we try to rule out the differentials, and thereafter we try to assess what is the depth of hemangioma, what is the extent, and what is the stage or phase of hemangioma, whether it's proliferating or it's regressing. Are there any complications or are there any associated syndromes? And then we try to assess the severity also using various scores. So uh, this is a commonly asked question to residents also, and this has got practical implications while seeing the patients. How do you differentiate your vascular malformations from your infantile hemangiomas? So, as I said, there is a female predilection in hemangiomas, whereas there is none in malformations. So, you have a typical proliferating phase followed by involution in hemangiomas, whereas malformations they either remain static or they grow proportionate to the body size of the child. The color again it's more bright red, whereas it may be bluish to slightly pinkish red in hemangiomas, in infantile hemangioma. The consistency may be different, the associated syndromes are different, and histology almost never done, but still for academic purpose, these are GLUT1 positive. Infantile hemangiomas are GLUT1 positive, whereas your vascular malformations are negative for WT1 Wilms-Tumor 1 stain and GLUT1 stain. So the second thing that you try to see is the depth. So again, a thing is if you have this strawberry sort of proliferation on the skin, but you don't see any associated perilesional edema or swelling, then it is likely to be a superficial hemangioma. Very few hemangiomas are actually superficial hemangioma because many times they have got a deeper component, and you can appreciate here that you can see the red lesion, but beyond the red lesion there is a lot of swelling. That means there is a dermal and a subcutaneous component to it, which here it's visible in naked eye also, but many times you find that in ultrasonography. So this is a mixed hemangioma, and in deep hemangiomas, you hardly see anything on the surface. It's only a deep swelling that is present, and here it becomes sometimes very difficult to differentiate it from a venous malformation. So again, anatomical location is important to classify whether it is what sort of segmental hemangioma or it's a focal hemangioma, and it has got prognostic implications also. This is an older image. What was initially thought that this S1 and S4 regions, if you can appreciate on this picture, the supra-orbital region, and these are the nerve, basically distribution along the nerve trunks of the trigeminal nerve, and the ones which are on this S1 distribution especially, they were a lot, I mean, they were considered to be more predisposed to development of facies syndrome. But in our current understanding, the whole of the forehead, this whole of the forehead becomes a risk factor for development of infantile hemangiomas. And although your lower face hemangiomas, that is the in the S3 region, the jawline, they are at higher risk of development of airway hemangiomas, and then that becomes an emergency. And S2 in the maxillary region also, even those can have facies syndrome, although risk is somewhat less. And this is a more recent classification. Again, what these authors have suggested that there is a C-type distribution of segmental hemangioma around the auricular region, and they say that again this has been missed often in the past, and they have tried to highlight this C-type segmental hemangioma in the periauricular region. An extent of hemangioma, as I said, your whether it is segmental or localized hemangioma, this has got again prognostic implication and clinical implications. And again, what sort of stage of hemangioma is coming to you, whether the child is coming to you in the proliferative phase, then there is a higher likelihood that your intervention with beta blockers or other medication is going to provide a good relief to the patient. Whereas the patient comes to you at a later stage in the regressing phase, there isn't much that you can really do. And then you try to assess the syndromes. There are several factors for it also. One is segmental hemangioma. Uh, it was earlier thought that if it is more than 5 centimeters in diameter, Some schools of thought say that if the area is more than 25 centimeters square centimeter, or if there are multiplicity of lesions, all these things predispose to various syndromes. But we should be aware of what we are looking for. The facies syndrome, especially of the segmental hemangiomas of the head and neck, lumbar syndrome, especially if it is around the pelvic area or the lower limbs. We should be aware of this, the sacral syndrome and the pelvis syndrome. And this, our risk of detection of this syndrome should be high, and our investigation should be directed accordingly. So, we've discussed this that segment hemangiomas of the head and neck, they uh, they are at high risk of facies syndrome, especially if they are more than 5 centimeters in diameter. And the screening should be done with ultrasonography in kids less than 4 months and with MRI for children more than 4 months. There is an issue with ultrasonography that, especially for periorbital hemangiomas, it may actually not pick up your deeper component also and your intracranial involvement. So MR is considered the investigation of choice in all cases of hemangioma. But we understand that the risk of using sedation and use of gadolinium contrast in very young infants, that is less than 4 months of age, there are inherent risks with that also. So some people do defer this MRI for a later age also, but uh, your ultrasound should be done for children less than 4 months and MRI for more than 4 months. And again, you try to look for clinically also and on investigations, you look for genitourinary anomalies like imperforate anus, renal defects, or genital or sacral skin tags, and other anomalies. So again, visceral involvement, typically if the number of lesions is more than 5, it's not a hard and fast rule, but this is what we generally consider. If it is more than 5, then you look for an involvement of internal hemangiomas in the liver and GI tract, although the management may remain essentially the same. High output failure is not really a practical problem with majority of these patients, but still it is all many times mentioned. The same is the case with hypothyroidism, often mentioned in the books that it can be a serious concern. But if you follow these patients over a long time, hypothyroidism is not practically a very serious risk factor for even with multiple hemangiomas also. So look for complications, whether this is ulceration because it is going to leave behind significant scarring and disfigurement, then ophthalmic complications in the form of glaucoma and disfigurement. And another challenging thing is the hemangioma of the tip of the nose because again they leave behind significant disfigurement. Coming to the severity assessment that is often done with hemangioma activity score. This is a very well validated score and it is easy to do also. You have to look for the depth of the hemangiomas, you have to color of the hemangiomas and how it is changing in subsequent sessions or subsequent follow-up and presence of complications like ulceration. It gives you a fairly good idea whether the hemangioma is improving adequately or not. We have been using recently a dermoscope, trying to devise this. This is still under peer review. No, it's not a published thing. So again, based on clinical evaluation only, we have to try to correlate with the clinical findings with the dermoscopic findings in terms of color of hemangioma, the patterns of vessels, whether these are globular vessels or comma-shaped vessels or wavy vessels, presence of eccrine openings and ulceration and discharge. So if the hemangioma is actively proliferating, then you see this glomeruli or dotted or these globular sort of dots in hemangioma. And if it is regressing, your chances of finding your eccrine openings become much higher. And your color also changes from bright red to pinkish red, or your vessels which are in the subcutaneous tissue, they become a lot more prominent as the hemangioma is regressing. And this has shown a very good correlation with your hemangioma activity score, and we hope to uh, validate it further in a larger subset. So hopefully this should come up soon in publication also. So coming to radiological assessment, as I said, your ultrasonography is the safest investigation to do, but MRI is the best one. So all it's not just the to see look for your syndromic involvement. Even the radiologic, your lesional ultrasonography is very important. As I said, a lot of superficial hemangiomas on clinical examination may turn out to be mixed hemangiomas on lesional ultrasonography. So I would advocate doing lesional ultrasonography, your plain USG only or Doppler USG in all patients of infantile hemangioma to correctly assess the depth of hemangiomas, and then again at the end of treatment also. So, your this is your typical hemangioma on ultrasonography and the Doppler image also. You'll see a lot. You look for vascular density also, and this vascular density keeps on decreasing as you treat the patient. So, coming specifically to treatment, so uh, some time back only, active non-intervention again was one of the preferred therapies or modalities. Even today, that holds true also, but with the advent of very safe therapies like topical beta blockers and oral beta blockers, a lot of hemangiomas can be treated and can be treated safely with very good uh, clinical effect. So, what are the indications for intervention? One, if it is a life-threatening or function-threatening hemangioma, like the impairment of vision or hearing, then airway and feeding problems, or there is heart failure. Anatomical location where it is going to leave behind a lot of uh, aesthetic or cosmetic disfigurement, complicated hemangiomas, and a psychosocial sequelae. If you think that it's going to cause such so much disfigurement later in life, it's better to treat early and treat adequately. So these are the various interventions. So beta blockers, whether topical or oral, they are the mainstay of therapy. Steroids, although mentioned, are hardly used now, and rest of the things are also almost never used. So we'll concentrate on beta blockers. They have become the first line of therapy, and whether it is your propranolol or it is atenolol or topical timolol or oral nadolol. So ever since these were introduced, these have become the mainstay of therapy. Your topical propranolol, we don't have it in India right now, but whatever studies have been done outside, they show very good benefit. Even topical timolol, although there is a lot of data on topical timolol also, that it is quite efficacious and safety, but in our experience, it is useful mostly for superficial hemangiomas. Once the hemangiomas become mixed or deep, then its efficacy becomes much limited. So how do these act? These act by one, it decreases the vasodilatory transmitters like nitric oxide, leading to vasoconstriction of the capillaries, which brings about the immediate effect. That is, within 24 to 48 hours, the parents will see that the improvement has started because the hue of redness also changes. But the major effect is because of the blockade of growth factors like vascular endothelial growth factor, FGF, and MMP that causes apoptosis of the endothelial cells. And there is a blockade of GLUT1 receptors, and there is additional inhibition of the RAA axis. All these factors contribute to apoptosis of endothelial cells mediated by propranolol. So how do you evaluate before giving beta blockers? It's very simple. Only a baseline ECG is sufficient and an adequate history also. If there is history of heart blocks in the family or bronchial asthma in the family, then you should be cautious about giving beta blockers. So you look for the PR interval. There should not be grade 1 or grade 2 AV blocks. There should not be sinus arrhythmia, bradycardia to begin with. And generally, CVS monitoring is not advocated subsequently unless you are going to escalate the dose. And echo is again not advised as a routine thing. But if there is some ECG anomaly, then you go for echo to look for any structural anomalies of the aorta. So again, this is something some people say even ECG is not important, adequate history is important, but we always do ECG before starting beta blockers. So target doses between 1 to 3 milligram per kg body weight. Generally, it is 2 milligrams. We start at 1 milligram per day propranolol in divided doses, and then you escalate after a few days to 2 milligram per kg, and if needed to 3 milligram per kg, and start from a low dose and then escalate. And then the contraindications are, as mentioned, the AV blocks in sinus bradycardia or other if there is hypersensitivity to propranolol. And again, you should monitor for, it's very difficult to monitor blood pressure in such young patients. We are not very accustomed to that. But heart rate is very easy to monitor. You should monitor that for a couple of hours, maybe in your OPDs only. So that is a best measure of any potential toxicity of beta blockers. These are not uncommon, but the serious ones are not really common. So better to start during daytime only so that you can monitor. Make sure that the child is being fed, breastfed very regularly so that there is no risk of hypoglycemia. If the child is having any URTI or any other viral infection in febrile episode, you can omit a couple of doses and then start as the child becomes better. So it's very safe even in very young in neonates, also in low birth weight children also it is very safe. So there are no major adverse effects of beta blockers, especially propranolol. Although we use atenolol a lot more compared to beta propranolol, but both atenolol as well as propranolol are very safe in infants, in very young infants and preterm children also. So how long do you give this thing? So you generally, you give once you start it, you should give it for 9 to 12 months, and you should make sure that you have crossed the proliferative phase of infantile hemangioma before starting. Otherwise, the chance of relapse are higher. And again, I said before stopping propranolol or beta blocker, it's better to do a repeat ultrasonography and make sure that the vascularity is completely gone, and then you can taper within a month and then stop it. So in about 9 to 12 months, you should stop your beta blocker. So these are the photographs as you see of the Doppler also and sonography as they change. The echogenicity changes, and I'll just quickly run through the rest of the slides. So in various meta-analysis, it has proven to be very safe, and it should be the standard of treatment. And there are again some comparison of propranolol versus uh, atenolol, and they have been found to be somewhat similar in terms of their efficacy. So this was one of the studies from our center, one of the initial studies from our center, where propranolol was compared with prednisolone, which was the treatment at that time, almost 10 years, 12 years back, and a combination of propranolol plus propranolol plus steroids. So what was really seen that okay, all the groups were benefited, but the best effect was with propranolol. So propranolol was better than steroids, and it was better than combination of steroids and propranolol. And the adverse effects were more in the combination group. So what happens is that your is going to suppress the HPA axis, and that can increase the risk of hypoglycemia in these children. So it's better not to combine your propranolol with steroids. And this was the subsequent study which was done again. We started with comparison of propranolol 2 milligram per kg body weight with atenolol at a low dose of 1 milligram per kg body weight. We were not sure what should be the ideal dose of atenolol. So again, both the groups were affected, but what we saw that propranolol at a dose of 2 milligram per kg body weight was better than atenolol at a dose of 1 milligram per kg body weight. These are some of the photographs from that trial. So this is the propranolol. I think this is a propranolol group. Again, becomes better, but this is the atenolol group, the liphemangioma, which is otherwise also difficult site. So subsequently, then we hiked up the dose of atenolol to 2 milligram per kg body weight and compared it with propranolol 2 milligram per kg body weight. And then we see that at this dose, atenolol is equally efficacious as propranolol. So we have more or less changed from propranolol to atenolol. So these are again some of the photographs from this is the propranolol group and this is the atenolol group. You can see the marked improvement with atenolol also. So why are we searching from propranolol to atenolol? Because of the theoretical risk of neuropsychiatric manifestations with propranolol, which crosses the blood-brain barrier. So again, and we have seen in our data also that there is we called up patients who received propranolol between 2010 to 2015, and 7 years down the line, the risk of ADHD was slightly higher in the propranolol group. So it has been seen in some other studies that the risk is not significant, that propranolol does not lead to increased risk of ADHD, but our experience was somewhat different, that the risk was significant. So we have more or less changed from propranolol to atenolol. And more recently, there is some data on itraconazole also, which is supposed to be effective acting through the sonic hedgehog pathway. This was one such case report from AIMS Delhi by Vishal, and this is facies syndrome, which was treated with itraconazole with good effect. All in all, I'll finish my presentation with that you examine thoroughly and look for all the complications and other resolution of infantile hemangioma. Consider lesional ultrasonography to assess the depth of hemangioma, and then at the end of the treatment also. Topical timolol does work, but mostly in superficial hemangiomas. Have a low threshold to start beta blockers, because oral beta blockers, because these are very safe medications even in less than 8 weeks children. And do consider changing your therapy from propranolol to atenolol 2 milligram per kg body weight. These are all my acknowledgements, MD residents and my colleagues who have contributed to various studies. Thank you. Thanks a lot.
Thank you, Rahul sir, for that was a master class on infantile hemangiomas. I think you covered everything from clinical features and diagnosis, and not only the updates on management. Thank you for that. So our next speaker is Dr. Rajiv Roy Barua. Sir is the Associate Professor of Pediatric Surgery at Guwahati Medical College and Hospital, Guwahati. And his special areas of interest are neonatal surgery, pediatric gastroenterology, and vascular anomalies. So we welcome you, sir, and looking forward to hearing.
Share kore dia. Sharing kora. Submission. Go back kora. So itu kati diye. Niye ke hasil. Share to draw. The DB kunkana.
Sir, we are visible.
Am I audible and visible, sir?
Yes, sir. Just make full screen.
Share to आपको दिया सर. Share देखना screen to दे दिया just. आपको এটা तो share बोली आसन दिखा. Itu tick करी, itu share करी देना.
So we can see your screen. You just have to make it full screen and start. We can see your
full screen करी दिया. Full screen करी दिया. Full screen. itu.
Good evening, President of ISPD, Dr. Jaigar Thamas, sir. Immediate past President, Dr. Sandipan Dhar, sir. Secretary of ISPD, Dr. Maitri Panda. Dr. Rahul Mahajan, Academic Coordinator, Dr. Ram Gulati. And the distinguished guest for this webinar. A warm welcome to each one of you for sparing your valuable time to attend today's webinar. At the outset, I would like to offer my sincere thanks to the office bearers of ISPD for giving me the opportunity to speak on the topic update on surgical management of pediatric vascular anomalies. I'm Dr. Rajiv Rai Bura, a pediatric surgeon from Guwahati. I work in Guwahati Medical College, speaking in front of this august gathering of eminent dermatologists from all over the country. This will be an interactive session, and so please be free to use the chat box or share your thoughts and queries with me. So vascular anomalies are defined as congenital lesions of abnormal vascular development, which encompasses a wide spectrum of lesions with varying degrees of severity ranging from isolated and innocuous lesions to those that are disfiguring and disabling to those that signal the presence of a more complex syndrome. Owing to the complexity and heterogeneity of these lesions, as well as confusions surrounding their classifications, vascular anomalies are often misdiagnosed. In 1982, Mulliken and Glowacki introduced an organizational system for vascular anomalies based on their pathological characteristics, dividing them into binary groups. In 2018, the classification system was updated in the international study for the vascular anomalies, and the vascular anomalies were again divided into vascular tumors and vascular malformations based on their endothelial cell characteristics, clinical presentation, natural history, and histopathological characteristics. This is the abridged flowchart of the Society for the Study of the Vascular Anomalies. And these vascular anomalies are divided into vascular tumors and vascular malformations. These vascular tumors are again subdivided into benign, locally aggressive, and malignant variety. And vascular malformations are divided into simple, combined, and other anomalies. Now the vascular tumors are divided into benign. Those in this benign group, there are infantile hemangiomas, congenital hemangiomas, pyogenic granuloma, and tufted angioma. And in the locally aggressive varieties, there were Kaposiform hemangioendothelioma and Kaposi sarcoma. And in the malignant variety, there is angiosarcoma. In the vascular malformations, they are again divided into three groups. Those are simple, combined, and other anomalies with some syndromes. In the simple variety, there are capillary malformations, venous malformations, AV malformations or fistula, lymphatic malformations or primary lymphedema. Then second is the combined variety, and in the third vascular malformation are the other anomalies like Krippel-Trinoni syndrome, Parkes-Weber syndrome, Sturge-Weber syndrome, and some other rare syndromes. So in the recent years, there is notable progress has been made in the imaging techniques and genetic testing, enhancing our ability to diagnose these conditions. There is a comprehensive multidisciplinary approach to be involved. Specialists coming from the dermatology department, radiology, pediatric surgery, and genetics is often required to ensure an effective management of these conditions. There are different modalities of treatment, like conservative treatment with beta blockers, with propanolol, timolol, or some other beta blockers, then steroid, injection sclerotherapy, cryotherapy, laser treatment, angiographic embolization, angioplasty, or binding of feeder vessels, use of angiogenesis inhibitors, and finally the surgery. Today, I will discuss about sclerotherapy, interventional radiology procedures, laser, and surgery. And now coming to the specific considerations for different types of vascular anomalies. Like in the AV malformations, we primarily manage these AVMs by endovascular embolization with surgical resection considered only in cases where complete embolization is not possible. The venous malformations were treated with sclerotherapy. This is the mainstay of treatment, with surgical excision reserved for large symptomatic lesions, especially on the face. Capillary malformations were treated preferably with laser therapy, And lymphatic malformations, depending on the size and location, were treated with surgical excision, sclerotherapy, or laser therapy. In our day-to-day practice, we come across a lot of infantile hemangioma cases. These are the benign vascular tumors, and they present in estimated about 5 to 10% of the population. So these are some of the clinical photographs we had come across in our department. Facial and oral cavity hemangiomas always of clinical importance and require early diagnosis and appropriate treatment. Tongue hemangiomas show a great risk since the tongue, being a mobile organ, is susceptible for trauma and subsequent complications. We have seen that complete regression or spontaneous complete regression of hemangioma occurs in about 30 to 60% of the patients by the age of 4, and in 70 to 76% of the cases by the age of 7 years. Due to this long period of spontaneous resolution, there is a possibility of ulceration, bleeding, respiratory and ambulatory problems, ptosis or astigmatism, even amblyopia in hemangioma of the eye. So massive hemangiomas alter skin structure by stressing or injury to the surface texture, causing disfigurement. So coming to some of the hemangiomas, specifically located into some specific areas, like these are the clinical photographs of hemangiomas or other vascular malformations affecting the nasal area. So I will discuss some of the surgical management or interventional treatment management of these cases. So these are the children photographs of the children affected with vascular anomalies in the nasal area. These are the photographs of patients with leaf involvement. These are the pre-treatment and post-treatment photographs of the different cases where there were vascular anomalies in the eyelid, around the eye. You can see after 12 months of propranolol therapy and with local sclerosin injection, foam sclerosin injection. This is after 2 years of the treatment, and this was after 6 months. So these are some of the clinical photographs. These are the clinical photographs of patients affected in the facial region. And these are the clinical photographs where the patients were affected with lesions in the oral cavity. This patient, it's a mixed variety of AVM along with hemangioma. This patient, about 12 years old girl, presented to us in the casualty, and she came from a faraway place, about 3 hours journey from Guwahati, and we immediately took her to the cath lab, and then we did embolization, and she's okay. I'll show some of the photographs of this patient also later on. And these are some of the other photographs of hemangioma or vascular anomalies presented with lesion in the tongue. So I will not go into details about the mechanism of action of propranolol because it has already been covered by Dr. Mahajan. So these are the clinical photographs of patients where oral propranolol was used. These are the pre-treatment photograph and these are the post-treatment photograph taken after 9 months to 12 months after initiation of the therapy. You can see there is significant decrease of size of the lesions. Now coming to the treatment where there was sclerosin treatment was given. So generally we had gone for sclerosin treatment when there was incomplete remission with oral propranolol alone. Before we used to give direct injection of sclerosin into the lesion, but now since last 5 years or to 6 years, we are making a foam injection. We are giving the sclerosant. We are instilling the sclerosant into the lesion by making foam. So I'm just showing my some of my photographs in where we had created a foam. I will just show you how we do it. So as we know that liquid sclerosant when injected is diluted by blood inside the lesion, thus reducing the delivered concentration to the vessel wall. But the foam, if we make foam, there will be more of surface area. So it will displace the surface area will be more so that the contact area will be more. So it will displace the blood and comes into direct contact with the endothelium. Thus the efficacy of a given concentration of sclerosant will be more and the efficacy will be enhanced with a foam preparation. So we take these patients to our operation theater and under IV sedation because they are pediatric patients with IV sedation. We take help of two 10 ml syringes, 16 gauge IV cannula, a three-way cannula, and the foam, the sclerosing agent we use were polydocanol, and the trade name is Esclerol. So we take the dose is 1 milligram per kg per dose, and it should not exceed 2 milligram per kg dose. So these are the clinical photographs where we started with the sclerosing injection in the OT. So you can see this is the foam. How we make a foam? We take 2 ml of sclerosing and 4 ml to 5 ml of air, room air into the other syringe, and then we insert the cannula inside the lesion, and then we close this way, the three-way, and then we make foam by to and fro movement about 20 to 40 times. If we 20 to 30 times, if we make to and fro movement of the syringes, there will be a good foam formation. And then we, after the formation of the foam, we open the way to deliver the medicine inside the lesion, and then you can see that now we are injecting. This foam also helps in seeing the uh, seeing the effect of or the seeing of the going of the sclerosing inside the lesion. Like the air contained in the foam is ecogenic. So while we do this under ultrasound guidance, then we can see where it is going. So always, sometimes we use the ultrasound guidance. And in fact, in most of the cases, we use the ultrasound machine when we do the procedure. So there are different sclerosing agents used, like polydocanol, sodium tetradecyl sulfate, sodium morphate, sodium citrate, monoethanol amine oleate, invert sugar, boiling water. But in our institute, generally we are using polydocanol. Now coming to the embolization of the vascular malformations associated with AVM. Indications of embolizations are vascular anomalies of the oral cavity, hemangioma of the tongue, rapidly progressing lesions, symptomatic lesions with life-threatening bleeding. As we know that embolization reduces the number of abnormal connections between the blood vessels inside the lesion. So the materials used for these procedures are medical glue, medical coils, plugs, cyanoacrylate polymer, polyvinyl alcohol, foam particles. So how we do this embolization? This procedure is done in the cath lab of our Department of Radiology with the help of intervention radiologists. Generally, we puncture the femoral artery or radial artery under local or general anesthesia under full aseptic condition, and a 5 or 6 French arterial catheter is negotiated over the guide wire through the artery. Then the feeding vessels are selectively catheterized after a diagnostic run confirmed by a DSA, digital subtraction angiography. And the embolic agent is pushed through the catheter and the check DSA is done to see the obliteration of the vessels. After the procedure is over, the system is removed and compression bandage is applied over the puncture site. These patients most of the patients are discharged from the hospital within 24 hours of the procedure, but those who have considerable pain may have to stay longer. So as I had shown the photograph of this girl of 12 years, we took her to our cath lab, and then after this is the photograph of after about 1 week, because we had to admit the patient, and you can see there is no bleeding, and then it has gradually the lesion got healed, and then after 6 months she came, and this is completely gone. And in this photographs, I can show you that the glue particle, this is the catheter we had inserted, and the glue we had inserted into this part, and then you can see it had gone into it. This is another boy with AVM with superficial hemangioma also. Here you can see the guide where we had inserted the glue. And then this was the pre-treatment photograph. This is the post-treatment photograph. After 6 months, we took this photograph. And this is a new case. Here you can see these are the pre-treatment photograph. This is the post-treatment photograph. So precautions to be taken during this procedure is that the right choice of the right embolic agent is very specific. It should be specific for a specific lesions. Generally, in this tongue hemangiomas, we use polyvinyl alcohol gel foam. The embolization should be specific to prevent non-target embolization of the other vessels. Because if you target some other vessels where it is not involved, there will be necrosis. So it should be very precise. We should be very careful. And we should be careful that there should not be any thromboembolism in the internal carotid artery in the lesions of the tongue, or sometimes we use this for parotid hemangiomas also. This is a very new case. Last OPD, I got this case. So we had not started treatment till now. This is a pre-treatment photograph. I think in the next week, I'll do the treatment. Then coming to laser plays a crucial role in the vascular malformations by selectively destroying the abnormal blood vessels within the malformations. There are different types of lasers used, like in the pulse dyed laser being commonly used for superficial lesions, ND-YAG for deeper lesions, and diode laser for smaller vascular malformations in cutaneous or subcutaneous area. There are some key points about laser treatment for vascular malformations. It causes selective destruction. So it targets the hemoglobin within the blood vessels, selectively hitting and damaging the abnormal vasculature while minimizing harm to the surrounding tissues. And it is minimally invasive, so there often requires only topical anesthesia in most of the cases. Laser acts by light absorption. When laser lights are delivered into the affected area, the hemoglobin in the blood vessels absorb the energy, and it creates heat generation, and it helps in the coagulation and destruction of the abnormal vessels. And then the body naturally reabsorbs the damaged blood vessels, resulting in the reduction in the size and appearance of the malformation. Then coming to the surgery, this is the last resort we should think. Surgery is the important tool for management of a vascular anomaly. It should be performed as part of a comprehensive treatment plan. The goal of the operative intervention should be the improvement of symptoms and quality of life, rather than the eradication of the lesion at the expense of the surgical morbidity. In this clinical photograph, you can see that there is, we had excised the whole of the hemangioma of the neck. You can see there is hardly any lesion left. Indications for surgery are failed medical treatment, localized disease, lesions that can easily be removed, leaving no significant cosmetic deformity, threat to function of the organ, ulceration, bleeding, and infection, and lymphatic malformations. In this patient with hemangioma of the tip of the nose, I'm planning the steps of operation like this. These photographs are not mine. I have taken. In the next few weeks, I'm planning to do planned operation along with my plastic surgery co-workers to do a stage operation. And in this photograph, you can see that this hemangioma had been completely been removed. In this patient with hemangioma of the lower lip, complete excision of the hemangioma had been done immediate post-op and after 6 months of post-surgery. This is the most recent photograph. 3 days back, uh, we had operated on this child of 10 years coming with pain abdomen, and the clinical diagnosis was the hemangioma of there was a vascular anomaly inside the intestinal lobes in the ileum. And then when we had seen that this is a big hemangioma in the terminal ileum, then we had to, it was a laparoscopic appendicectomy case. We prepared the case for laparoscopic appendicectomy, but we had to convert the case to open surgery. And then after uh, doing open laparotomy, we had to excise this part, the part of the intestine ileum where the hemangioma is there. And then this is after excision, we had done end-to-end anastomosis. So now coming to the last part of the deliberation, our take-home message for this deliberation is that propranolol is always the first line of drug for treatment of hemangioma. If there is failure of propranolol therapy, we consider for oral propranolol combined with intralesional sclerosing injection for 4 sittings at 6 weeks interval. And sclerotherapy is for cases where there is failure of propranolol treatment or in cases of lymphangioma. Ambulation is indicated in vascular malformations associated with AVM of peripheral organs, intraoral and tongue hemangiomas presenting with life-threatening bleeding and respiratory distress. Laser is for superficial lesions, and surgery is the last resort for life-threatening conditions, ulceration, and for cosmetic removal. Thank you for the patient hearing. And these are some of the beautiful photographs of Arunachal Pradesh. Please do visit Northeast India and enjoy our warm hospitality and the scenic beauty of the Northeast, the gateway of the Southeast Asia. Thank you so much.
Thank you so much, sir. I think that was a very enlightening lecture. And we as dermatologists, even those of us who practice dermatosurgery, don't move beyond sclerotherapy. That was a very enlightening lecture. So we'll move on to the last topic of today's webinar, which is going to be a case-based discussion of pediatric vascular tumors and malformations. And it's a pleasure to introduce the moderator, Dr. Neetu Bari. So, ma'am is the additional professor of dermatology at AIIMS, New Delhi. She has more than 150 publications and 50 chapters. Her areas of interest are pediatric dermatology and dermatopathology. Over to you, Neetu, ma'am.
Good evening, everyone. Sorry, I was not able to unmute myself. Now I am able to do. So, good evening, everyone. I'll start sharing my PPT before we can move. Right. So, thank you, ISPD Academy, Thomas sir, Rahul sir, and Dr. Ram Gulati for inviting me to conduct this panel discussion. And after 2 very enlightening and insightful lectures by Dr. Rahul and Dr. Rajiv. We will do some case-based discussion. We will discuss some important and practical points in the management of vascular tumor and malformation. And I have a team of esteemed panelists with me, the man himself, Dr. Rahul Mahajan, who is additional professor in PGI Chandigarh, and now he's a chairperson of ISPD Academy as well. Rahul sir, please welcome to the panel discussion. Dr. Rajiv Malakar, consultant, Institute of Child Health and Ramakrishna Mission Seva Pratishthan, Kolkata. Sir has a prime interest in pediatric dermatology. I just heard his lecture in Dermacon on hemangioma, which was really interesting and enlightening. So, Rajiv sir, please welcome to the panel.
Thank
We
you for the
just heard,
introduction.
we just heard Dr. Rajiv Ray, and he's an associate professor of pediatric surgery from Guwahati, and again, special interest in neonatal surgery and pediatric vascular anomaly. Welcome, sir. And Dr. Suman Patra,
Thank you so
my
much.
friend, he's associate professor in AIMS Jodhpur, and he has prime interest in dermatosurgery as well as pediatric dermatology. Welcome, Suman. We have Dr. Jereen Matthews with us, very vibrant assistant professor, Department of Dermatology, AIMS Bhopal. Again, she has a prime interest in pediatric dermatology. And Dr. Akash Agarwal.
Thank you.
Welcome, Jareen, and I welcome Dr. Akash Agarwal as well, who is an assistant professor in the Department of Dermatology, IMS and SUM Hospital, and he again has prime interest in pediatric dermatology and very active in ISPD activities. So Rahul sir just showed us this ISWA classification and how to classify vascular tumor, how to differentiate it from vascular malformations and syndrome associated with vascular malformation, whether they are capillary malformation associated syndrome such as Sturge-Weber syndrome, Klippel-Tinoni, phacomatosis pigmentovascularis, venous malformation, lymphatic and AV malformation. Sir touched upon how when to suspect Facey syndrome, and I'll take that thread and continue. Uh, we see facial hemangioma, segmental hemangioma, not very uncommonly, but we don't suspect Facey syndrome in all of them. So the first two cases are of segmental facial hemangioma. The second one may be classified as focal facial hemangioma, and the third and fourth cases are of capillary malformation on the face. So, though they are facial lesion, they are segmental, but probably the size as well as location, it is not hinting to an underlying syndrome. What about this case? So this is a young baby presenting with lesion. Bilateral auricular area we can see lesion, preauricular area, and even the nasal tip there is a hemangioma, and the lips, and even you can see on the upper chest. So extensive lesion. So should we suspect Facey syndrome here? We thought of that and we evaluated and we found. So, should we suspect faces in such cases, or should we stick to the criteria of large facial segmental hemangioma? Rahul sir, can we start with you, please? Because you
So,
just.
yes.
Just a
So,
second. Neetu ma'am, can you change it to slideshow? You seem to be on the presenter mode. People are not able to see the slides. Can you change it to
Yeah,
slideshow,
yeah,
please?
yeah, sure, sure. I'll do that. And show. Play from
while you're
current
just
slide. Can you see now?
Thank you.
Right, right.
so like for if we're talking about infantile hemangiomas, so one is yes, segmental hemangiomas are supposed to be more predisposed towards Facey syndrome, but that is one thing. There are other factors like in this particular case also. So it is this you can say size. Some say it is 5 centimeter segmental hemangiomas, and then the more recent school of thought is if it is if the area of the hemangioma is more than 25 square centimeters, which perhaps is the case in this case which is being discussed. Third
Right,
thing is the multiplicity of lesions in that particular segment also. If
right,
the head and neck only has, like in this case, three or more than three lesions, even that is considered as a risk factor for facies syndrome. So even if it is not per se in a classical sense segmental hemangioma, the individual size is more than 25 square centimeters and the number of lesions is more than 3, you should be suspecting facies syndrome. And then even if you say it is not even the forehead that is not involved, it is
Right.
mostly the jawline which is more involved. So
Right.
you would perhaps think more of
Mandible.
airway hemangiomas in this.
Right.
But again, in the same thing, presence of S2 segment, it's not just the forehead hemangiomas are more predisposed to faces, but that doesn't mean the S2 segment is not predisposed.
Right, sir.
So that is that even in that also it can be. So that would be my take. Number, segmental distribution, and the total area.
Right,
These
sir.
things in all should be considered.
Right. So two more point you added apart from being facial and segmental, number and total surface area and location. So maybe these 5 points we should check while suspecting a facies syndrome. Just going through this study, as Rahul sir showed in his talk, that you divide the face according to the segment. In these facial hemangioma, they found facies syndrome in 31% of the cases, so quite a high number. Probably they took large segmental facial hemangioma, and particularly in S1 and S3. So they found that if there are more than one segment involved, again that raises your suspicion of facies syndrome. So you can add that as a sixth point. And S1 and S3 will have a maximum association with facies syndrome. S2 rarely. It is not zero, but it is minimal. And like this case, they have shown bilateral S1 involvement with facies syndrome. This is S1 plus S3 with facies syndrome. And there was, of course, size matter. As Rahul sir said, if it is more than 25 centimeters square of body surface area, of surface area involved, then also you should suspect. And as was hinted by Sari, the study also showed that if there is S1, S4, more likely to have associated cerebrovascular anomalies. And if it is S3, more likely to have ventral developmental defect and airway hemangiomas, as was said. Rajiv Malakar sir, what about Sturge-Weber syndrome, sir? Any clinical clue in the facial capillary malformation when to suspect Sturge-Weber syndrome?
Before we go into this, can I
Yes, sir.
comment a little bit
Yes, sir.
about the
Yes,
previous
sir. Please.
question?
Yes, sir. Yes, sir. Please.
Facer syndrome can be associated with hemangiomas which are located on the neck, on the
Okay,
upper
sir.
trunk, and also on the proximal limb. Now we have a definitive diagnostic criteria for establishing the diagnosis of Facer syndrome.
Right, sir.
And if there is two major criteria apart from the hemangioma, and if the hemangioma is located even on the neck or on the trunk or on the proximal part of the limb, you can label the disease as a specific. Definitive diagnosis of faces can be made.
Right, sir.
Okay?
Right. Yes, sir. Yes, sir. Thank you, sir.
Thank you.
And Sturge-Weber, sir, any pointers for Sturge-Weber, underlying Sturge-Weber syndrome to a facial capillary malformation?
I'm not very. I'll pass this question on.
Okay, sir. Okay, sir. Right, sir. So, Dr. Jaireen?
Yes, ma'am. So, ma'am, for a facial capillary malformation, we do an ophthalmology screening for all children. Uh,
Okay.
Generally, because it's not invasive. We don't do MRIs unless the child has any neurological symptoms. We just ask them to, we explain the features of seizures, look for repetitive movements, lip spanking, and even for focal seizures. And we generally get a PEDS consult as well.
Right.
So I generally, because MRI findings calcifications often don't appear early in infants, and there is no role for prophylactic anti-seizure medication. So this is what we follow.
Right. So, every patient of every child of capillary malformation located on face, and you do ocular evaluation and neurological test, clinical assessment of
Only
syndrome.
clinical assessments, and
Right.
we ask the patient, we counsel the parents to report if there are any symptoms.
Right. Thank you.
I
So,
comment
Dr.
on
Suman, anything?
this.
Yes, sir. Yes,
So
sir.
basically, the concern about the radiological thing is because often you have to sedate the child.
Right.
The radiologists themselves are concerned about the use of gadolinium in early infancy. At least in hemangiomas and even in vascular malformations also, in less than 3 infants, ultrasonography as a screening tool for any structural anomalies of the brain also. And in fact, many people, even I don't really insist on going for MRI on the first visit also, but MRI can be done in less than 4 months because the risk of this Sturge Weber with neurological involvement is significant, especially if you have this supra in the forehead involvement. If it is there, then the risk is significant. And second is the risk of cerebrovascular accidents also. Your recurrent seizures, etc. Again, that is fairly high in Sturge Weber. Again, we don't use prophylactic aspirin, but there are people who use prophylactic aspirin also for the prevention of this recurrent strokes in young children. So I think as pediatric dermatologists or as dermatologists in general also, we should not be too conservative in radiologically evaluating port wine stains for Creutzfeldt Weber. We should actively investigate for it, even
Oh,
if it is clinically normal.
right, sir.
That would be my take.
Okay, sir. So you are saying because if we find the involvement prophylactic aspirin, we can start early and probably prevent seizure. So MRI can be done as early as possible if clinically we are suspecting. If clinically we see the lesion. So these were older studies when and the classical teaching when we were told that if both eyelids are involved, upper lid and lower lid, then there's high chances of underlying Sturge-Weber syndrome. If there's bilateral involvement, again, chances are much higher than compared to unilateral lesions. And V1 distribution. So it is similar to hemangioma. If the capillary malformation is there in V1 distribution, again the chances are high. And as Dr. Rahul is repeatedly telling, now the frontonasal fluid they are saying. So they are drawing this imaginary line, which is in the lower border of the line include the inner canthus of the eye and the top of the ear, and
Yes.
anything above that, if it is present, the suspicion of underlying syndromic association is high, and your threshold to investigate and order the investigation should be low.
And even the nasolabial, the nasal area up to the philtrum also. That
Okay,
is also often included also.
right. And this is just a small slide to show clippal this clinical clue that if there is a geographic port wine stain, then the importance of underlying lymphatic involvement, we should look for it, and the chances are high that patient may have a KT syndrome. Dr. Suman,
In addition, look for Mongolian spots.
right, sir.
And sometimes your Sturge Weber may be associated with phacomatoses also. So
Yes,
look for your pigmentary stains also
correct,
clinically.
right, sir. Dr. Suman, any other clue you use to see if there's an underlying syndromic association for both hemangioma and capillary malformation?
Ma'am, the hemangioma part has been described. From capillary
Right,
malformation, one is Sturge-Weber when you see in facial. But for Kippelinone, I think apart from this malformation, sometime in very early age we can see hypertrophy of the limb. So
right,
limb overgrowth is some clue that we can pick early.
correct,
So that is one. And segmental over spinal area like in back. These also sometimes associated with spinal malformation and associated that can have a lot of implication later in neurology implications. So these three, I think.
right, right. Okay, thank you. Rajiv Malakar sir, do you do
Yes.
hepatic screening, sir? Ultrasound, if there are multiple hemangioma as per the guideline, do you do it routinely?
Yes, I do. Especially if there is more than 5 multifocal hemangiomas are there,
Right,
you
sir.
should get it done.
Right, sir.
And basically, whole abdomen ultrasound should be done. That should, if you suspect there is involvement of other viscera, and among them, liver is the most important one.
Right,
It
sir.
should rule it out if there is whether there is involvement of the other organs or not.
Right, sir. Like in that first child where we showed multiple hemangioma, in that case it was limited to the face. Sometimes we see scattered lesion also in hemangioma. So if the number is more than 5, that's the cutoff based on various studies. So they have,
Exactly.
yes,
That is
sir.
the cutoff based on various studies.
And it is important because there are certain complications associated with the liver involvement of hemangioma, especially if it is multifocal or diffuse hemangiomatosis of the liver. Conjunctive hypothyroidism is one of them. Cardiac failure, abdominal compartment syndrome. So at least if there are more than 5 cutaneous infantile hemangioma, we should evaluate it. Sometime before 1 month of age, they may not be apparent on ultrasonography, and it need to be.
Can I make a comment about the thyroid problem that has
Yes, sir.
been
Yes.
commented upon by Dr. Mahajan? This
Yes,
is
sir.
something important you need to understand. We need to understand.
Yes, sir.
This is basically a reason a proliferative hemangiomas tend to have increased expression of type 3 iodothyronine dehydrogenase. This is
Right.
basically an enzyme which deactivates thyroid hormone.
Right.
And it is expressed in the proliferating phase of the disease. And as the disease regresses, as the condition regresses, the expression of the enzyme decreases and the hypothyroidism decreases on its own. But in a very proliferating phase of a very large volumetric hemangioma, especially on the parotid gland, of or there is extensive hepatic hemangioma, you should screen for hypothyroidism.
Right, sir. Right, sir. So hemangioma is not cutaneous limited problem. See, if you see if you see larger lesion, if you see multiple lesion, if you see lesion on a particular location, so we have to look for underlying syndromic association. We have to look for underlying organ involvement, because it may have significant implication. Though this study from BJD in 2020, it showed that even with the number of 2 to 4 hemangioma, many patients may have underlying hepatic hemangioma, and though even in presence of hepatic hemangioma the complications were rare, but they suggested that even with the less number of the hemangioma, you should at least clinically alert the patient for the sign and symptom which may require, especially organomegaly. So abdominal distension is one of them. If there are hypoglycemia or blood pressure is low, so all those sign and symptoms should be explained to the patient, particularly in multiple hemangioma. If we found a syndromic association, is our management different? Will it change our management strategy? This is also important. Akash, what do you think? Do you use propranolol in facies syndrome regularly, or you are little hesitant in those patients?
Good evening, ma'am. Ma'am, yes, I've used propranolol in a lot of patients with infantile hemangiomas per se.
Right,
In cases of AC syndrome, I'll be a bit, I would want a referral along with a pediatrician to go
right,
ahead with the same.
correct,
Especially in facies syndrome, we have to be careful that the stenosis part is usually a marker wherein you don't give propranolol. So maybe a consultation with a pediatric neurologist to rule out the same and then go ahead with propranolol would be a better and wiser option, ma'am.
right. Dr. Suman, anything to add? What is your
Yeah,
experience?
ma'am. Actually, one concern regarding that is when we are waiting for the MRI, we are not starting the patient with propranolol.
Right,
So, but the the incidence of cerebrovascular anomaly and in that those also risk of stroke is very minimal. The current studies have shown. So I usually start them on propranolol. Anyway, we started low dose 0.5 and gradually increasing it until we are reaching the adequate dose. Until then, we can get an MRI done. And
right,
so and I usually start with lower dose without waiting for MRI.
right. Rajiv Ray, sir, do you have any experience with facies syndrome, sir? Have you seen
Yeah,
syndrome?
in these cases, generally, what we do after 4 to 6 weeks of life, we start with the propranolol with the dose of, as Dr. Suman had told, that 0.5 milligram per kg per day,
Right,
and then gradually we increase. So after 4 months of age, we do MRI in our institute. So this is the line of management we follow in our institute.
Right. Because earlier when I was student, we were told that prednisolone is the treatment of choice, at least for Fay's syndrome. Because that time we were getting comfortable giving propranolol in sporadic hemangioma. But as the time passed, I think now we are becoming comfortable even with the Fay's syndrome with certain precautions for sure. And this was a JAMA Dermatol article, and they have given these precautions. They have mentioned that infant at risk of Fay's syndrome can be given propranolol safely, but after a thorough physical examination, echocardiography to rule out aortic arch coarctation, use a low dose initially, and use 3 times a day dose, and concomitant use of topical timolol should be avoided to avoid systemic absorption. So even with the syndromic association, even with the organ involvement, your first line of management doesn't changes. It's just that you become cautious of other complication and other association. Dr. Akash, how do you give it? Tablet or oral solution? That is, for me now, oral solution is dispersed in distilled water. Oral
Ma'am,
solution as such is not available in our country. So
ma'am.
sometimes I see the prescription half tablet, take 5 mg in the morning tablet, and what we do is we disperse it in the distilled water and give it with the help of dropper. How do
Ma'am.
you do it, Dr.
Ma'am, it
Akash?
actually, ma'am, it depends like on the weight of the child.
Okay.
If it is something below less than 10 years, those who can take tablets, you can give it. But because infantile hemangioma will be dealing only with less than 1 year of age, so it's better to give in solution form because we can give it more precisely the amount. It cannot go lower or higher, so we are sure of the efficacy that we are giving it. And per se, tablet is again cumbersome. If you give it to the patient, then breaking into half weight, if it is suppose say 3 kilos, so again further break it down, it becomes very difficult for the patient. So I think giving in a solution form is what I also prefer.
Right. Malakar sir, anything to add, sir?
No, ma'am, what you do is the gold standard in our setup.
Right,
That is
right,
how it is done. It
right.
is mixed in 5 ml of distilled water and dispensed accordingly in the concentration of 10 milligram per 5 ml.
Correct, correct, right, sir.
So
This
you give
was
it with breast milk only. I mean,
right,
this is what we do. I mean, you express the breast milk, and then maybe you dissolve 10 milligrams of propanol in 5 ml of breast milk,
right,
making it 2 milligram per ml, and then adjusting it according to the dose.
the twist, right,
Also, and because it is lipophilic, your propanol also it can easily dissolve in a lipophilic solution like breast milk.
right. These studies compared the tablet versus oral solution, but there they had the real oral solution, actual oral solution, and they have shown superior efficacy of oral solution, and they have given certain reason that it allows more flexible and accurate dosing. It has a better taste and it is absorbed more consistently. But what is available, that's how we give it. This is a photograph shared by Dr. Suman Patra, and this is a child of hemangioma. He has received propranolol for 10 months. And Suman's question is that how long should we now continue propranolol therapy? What is the indication to stop?
Actually, ma'am,
And
this patient came little late to us, like maybe around
right,
7, 8 months of age. So when we started now for last we already 10 months has been given. Now for last 2 to 3 months there is not no further improvement.
correct, correct,
So that was the question.
correct. Rahul Mahajan sir, can we start with you
How,
because
how
you
old
gave
is
us
the child? How
how
old
old
is the
is
child now?
Suman? How old is it?
Currently, it will be around near 2 year, like second 18, 19 months.
Right,
So, okay, even if it is 2 years or 18 months, so what happens is that generally your proliferative phase generally finishes by 15 months or 18 months, and in rare cases it can be prolonged up to 2 years also. So
right,
generally, I think 2 years is a good time to really think that your proliferative phase is really over in the natural course of disease. One
right,
can do what we do routinely even when we are trying to stop at 15 months or earlier, that we do a repeat ultrasonography, both the your what do you call as A scan or B scan ultrasonography plus Doppler. So if you don't see any vascularity, then it is a good time to taper and stop in next 2 months or so. If you still see vascularity, you can continue it for another 2 months or 3 months, and then do a repeat scan after 3 months to see if the vascularity is gone. So I think for practical purposes, if you don't want to go for sonography, 2 years is a good time to taper and stop it. And after that, it will regress in its natural course. But better would be doing a scan and then deciding what to do.
Right. Dr. Jerry, your thoughts, please.
I agree. I think for some children we have stopped a little earlier also, like sir said, around 18 months. So for all children, we haven't given up to 2 years, but 2 years seems to be the upper limit
Right.
that we consider that the proliferative phase is over.
Right.
Many
There
of the
is
Can I
a
cases
add a
still have
what we
comment?
some
call as
vascular
tardive
component at
hemoglobin.
that, but we generally expect it to regress.
So there is a small subset of tardive sort of hemangioma where, like sometimes on the lips, on the vaginal mucosa also, where the redness or the vascular component
Huh.
does persist for longer time, up to 3 years also. That is a very small subset, and that is why I said sonography may be a better guide to stopping rather than just the clinical assumption.
Right. Rajiv sir, you wanted to say something?
Yeah, yeah. In this particular case, suppose we had given the treatment for about 9 months to 10 months
Right,
and
sir.
it has not subsided. So, in the subsequent clinical, when the patient will come for OPD visits, we'll do ultrasound Doppler.
Right,
And
sir.
I think in this case, there is venous malformation inside. So, we can go for sclerosant therapy also, foam sclerosant therapy.
I have kept
So,
this question for you. So this is deep hemangioma, so not the venous. So venous,
yeah,
because deep hemangioma is one of the predictor of poor response, and there we would like assistance by you in the form of
yeah,
sclerotherapy and
yeah,
surgery.
yeah, yeah.
Yes. So these studies they are showing that at least 12 months of therapy, and particularly if for last 3 months the lesion has reached its maximum regression and patient is more than 13 months of age, you can clinically decide and stop the treatment. So these are the children showing good response, but then we have children not showing. So this is my patient, and Dr. Akash has shared one patient where large ulcerated hemangioma, and this is Maitri ma'am and Akash's patient, and after propranolol therapy it has improved, but there is still significant a large amount of lesion persisting. Akash, how did you approach after this? Are you continuing propranolol?
Yes, ma'am. Yes, ma'am. We are continuing. I think the child is about 9 months or 10 months. I'm
Right,
not very sure, but we are continuing. We are planning to
right,
give till 12 to 15 months, and then slowly we'll be tapering. So, because there is a risk of rebound if we stop
right.
it earlier. So, because the patient responded beautifully initially, because there was ulceration and secondary infections, we did give a course of antibiotics and a short course of oral steroids tapered over 2 to 3 weeks. And we have continued propranolol for about now 4 months. The patient is on propranolol, and the response is gratifying, but we will continue further.
So then it may be premature of mine to say the response is not great, because if child is
Yes,
still
ma'am.
9 month, 10 month old, we'll have to wait for at least 3, 4 months to
Yes,
decide
ma'am.
whether this can be categorized under good response or a poor response. Particularly if it is segmental, located on nasal tip, as Rajiv Racer showed in his PPT, and with deeper component. So those patients, they have, this study has showed if buccal and medial group facial lesion they divided into four, and the buccal and medial were showing the poorer response compared to the other two side. Rahul sir, you mentioned tapering of the propranolol before stopping it. Again, there are two thoughts about it. Should we do it or not?
So what we generally do is that we don't stop abruptly.
Right.
Even in that study that you cited of 13 months, wala study,
Yes,
I
sir.
mean, what you can do is you can maybe taper over just 1 month. So if you're at a dose of 2 milligram per kg, you taper it, you go down to 1 milligram per kg, and then in 1 month you just stop it, or 1 to 2 months.
Right.
It's a sort of standard sort of thing in any, whether it is methotrexate or any other medication.
Right.
Rather than stopping abruptly, taper it over 1 to 2 months and then stop. That is what we do.
Right, sir. Malakar sir, do
Yes.
you taper and stop, sir?
Yes, exactly. That is what the dictum says. You have
Right.
to taper propranolol over a period of 2 to 4 weeks. You do not stop it cold turkey.
Right, sir. This was a recent study. There they have shown tapering before propranolol was not associated with lower risk of early relapse. But in our institute also, sir, we are tapering, and we are probably rather going even slower tapering before stopping it. So Rajiv Ray sir, so like you showed in your excellent slides, so sir, are you taking naive cases also for the sclerotherapy or surgical excision, or the propranolol resistant and the residual lesions? Sir, unmute please, sir, yourself. Unmute yourselves.
Suppose in this case, you are asking about my comment on this case, or
No, sir,
what
like in
we,
your cases, are you taking even like the nasal tip hemangioma? Would you
yeah,
like to give him propranolol, reduce the bulk little bit, and then
yeah,
probably
really,
do the surgery? And till then,
will
child is also older.
first we'll go with propanolol for about 12 months, and
Right,
then we gradually taper within a month of 1 or 4 weeks to 8 weeks time, and then we do the surgery,
right,
the reconstructive surgery.
right. So this is a good case. Professor Somesh Gupta, who is our dermatosurgeon in institute. So infantile hemangioma, this was baseline. And intralesional radiofrequency ablation is, I'll show you a video later on how it is done. And was the initial result, and lip reduction surgery, and this was the final result.
Excuse me, man, can I make a point
Yes, yes,
about the tapering? There's the one point I missed out telling.
yes, sir, please,
The
sir.
most important factor in considering tapering of propranolol is that we know tapering does not have any significant influence on the rebound. But
Yeah.
while tapering, you can assess for rebound so that you can go after those.
Very, very important point. Yes, sir. At least for 6 months, 3 months, patient is coming to us, and we can evaluate.
When you are tapering, you can
Right,
see whether the disease, whether the condition is rebounding. If
right,
it is rebounding, which occurs in 25% cases of infantile hemangioma, then you can immediately increase the dose to the previous level.
correct, sir. True, sir. Sir, foam sclerotherapy, you have some experience, Rajiv Ray, sir.
Yes, in some of the cases where the only propranolol therapy didn't work, and in those cases, or in some cases, like in hemangioma of the parotid gland,
Okay, sir.
and hemangioma of the tongue also, and then hemangioma of the forehead, where the surgery may not be possible. In those cases, we go for foam sclerotherapy. Before, we were not using foam sclerotherapy, but
Right,
nowadays, in all cases where we go for sclerotherapy, we do foam sclerotherapy in
right,
our operation theater.
right. And this is something, an interesting term, sandwich therapy. So here they are combining intralesional bleomycin with propranolol therapy, and are naming it as sandwich therapy, and have found good result. So the key point is that apart, if there is a deep component or a residual component, so there are other modalities available like sclerotherapy, surgical reduction, intralesional radiofrequency ablation, and which may help in further improving the cosmetic outcome of the lesion. So these are the type of patient where I would go to sirolimus therapy now. This is capillary lymphatic malformation, and sirolimus is working very well in these patients. Dr. Jareen, what is your experience with sirolimus? Can I please ask which type of lesion you are preferring use of
Uh,
sirolimus?
yes, ma'am. I prefer to use it for low flow malformations that are quite large. So
Right.
most of our low flow malformations go to interventional radiology for foam sclerotherapy or surgery. But when it is very large, when it is compressing vital structures, so sirolimus seems to be a good rescue in such situations. It tends to bring in the size sometimes makes it more amenable to some surgical intervention or debulking. Second is, of course, in tumors with Casabac merit. These are
Right.
the two situations, and the response has been good. I think more than 80 to 90% respond. But we have had a case recently. We had a child whose venous malformation did not respond.
Okay. Right.
Ma'am,
When
can I
you say
make a
slow
point?
flow, do you mean lymphatic or capillary or venous? Which
Ma'am, lymphatic and
all
venous. Lymphatic and venous
lymphatic?
is,
Right.
yes.
Right. Suman, you were saying
Yeah,
something?
ma'am, I was saying that in my whatever I did in little experience, if lymphatic and capillary still responding well, venas are very poor
Right.
responders.
True.
Venas are
But my venous, I don't think I'm even giving in venous malformation sirolimus therapy. Capillary and lymphatic, particularly lymphatic with capillary sirolimus I'm using. And KMP, of course, we will see few cases of Casebic merit and KMP where sirolimus. Now it has changed our perspective of or our look of how we manage these patients. Now, Vin Kristin, Prednisolone, they are out of question. Now we are using sirolimus as first line of management. Rahul Mahajan sir, what do you which in which condition you are using it, sir? Sirolimus.
Capillary malformations and sometimes yes in venous malformation also. But I feel that the response is not very dramatic.
Right,
It
sir.
is good, appreciable. Uh, like in some cases of blue rubber bleb also,
Right, sir.
these they do respond. What has happened is that many times these kids keep on getting some new lesions in blue rubber bleb also
Right,
in the
right.
kidney lesion. So that decreases. So I have a patient who has been on sirolimus for almost last 10 years. She's a 12 years old girl, and for the major part of those 12 years, she has been on sirolimus without any major adverse effect. And so the bulk decreases to some extent, but not, I wouldn't say it's a big dramatic effect, but where there was nothing to treat, it's a good option. So again, a combination of your interventional radiologist, a vascular surgeon, and a dermatologist, that is important, because perhaps sclerotherapy is the best option, and then surgery is even a better option. And if that is not amenable, a lesion is not amenable to either of these two, then sirolimus is a good option in such cases.
How many years you said, sir, she's on sirolimus?
Almost 8 to 10 years. 10 years.
10 years on
Yes.
sirolimus. Right, sir. Malakar, sir,
So
any other?
safety is not bad. Safety is
Right,
quite
sir.
good.
I agree, sir. I agree. Malakar, sir?
I'm sorry, I do not have any practical experience
No,
with
yes,
sirolimus
no
till
problem.
date.
Yes, sir. Yes.
Everything is theoretical that I know.
Right,
Thank
sir.
you.
Right, sir. Dr. Akash?
Ma'am, same here. I've not used
Oh,
sirolimus till now, only
right.
theoretical.
Correct. These are rare conditions anyway. So, lymphatic malformation. So, pick three CA mutation, particularly lymphatic malformation. It has been used in KT Club syndrome. Blue rubber blab syndrome. There are certain reports. I'll skip the articles. These
So
are few of
some
our patient. I'll show you. This is with topical tacrolimus, oral tacrolimus. Again, I think lymphatic capillary are responding well compared to other form of vascular malformation. Blue rubber blab, when Dr. Rahul was in AIMS, we started for one patient. Thereafter also 2 or 3 patients we have given variable response. Few patients are responding, others are not. If we see these studies, what I feel is, because I will vouch for its efficacy in KMP, Casebic merit syndrome. So what I feel is, according to this review of literature, that their anemia and hemoglobin is improving for sure. So maybe the conjunctive coagulopathy is improving even in these patients as a first line of this thing, first mechanism of the action, and probably slowly it will go to the angiogenesis, inhibiting the angiogenesis and reducing the size as well as number of the lesions. So these are the studies, and showing hemoglobin level rapidly stabilizing, D dimer level improving even in the patient of blue rubber blab syndrome. Casebic merit, this is Dr. Suman Patra's patient of KMP, of caposiform hemangioendothelioma, improving with sirolimus. These are our patients of, so this was first patient of KMP which we saw, and we treated it with vincristin and steroid, and it didn't end well. But after the second patient, once we found sirolimus, we are not going back to any other form of therapy now. And safety, as Dr. Rahul sir said, it is a safe drug. Initially, we used to do sirolimus level for initial few patients, but now since we have become familiar and it's a costly investigation, and we are not finding much use of it, so we have kind of abandoned it. Rahul sir, you are doing it
No,
sirolimus
no,
level?
not really needed.
Right, sir. Fasting lipid profile, blood count, and routine electrolytes will be sufficient. This was case shared by Dr. Jaireen. This is a venous malformation of. Dr. Jaireen, would you like to share the story of the patient?
Yes, ma'am. This was a child, a 4-year-old child. The parents noted a compressible bluish lesion from the age of 2.5 years. They started noticing after they could retract the prepuce.
Right.
No complications, no pain, bleeding, or change in size. But the mother was pretty concerned over future complications, especially I think because of the sight and bleeding. So it was initially seen by the pediatric surgeon as well as the intervention radiologist. So because of the potential for tissue loss at this site, they didn't want to go ahead with surgery or sclerotherapy. So we started sirolimus. But 3 months and no significant response. The lesion is exactly the same. So anything else we can try. Currently, the plan is conservative management,
Right.
and yeah, there's no evidence of pain or thrombosis. So what we discussed in the vascular clinic is there's no need for an urgent intervention. But what
Right.
would the appropriate intervention be? I would like to hear from the panelists.
I can show you two of my cases and then we can ask our esteemed panel. So this was probably more like a capillary lymphatic rather than your venous lymph malformation case.
Yes.
And it responded well to oral and topical sirolimus. So initially we gave oral and then we went to topical. And this is a case shared by Professor Somesh Gupta in our department, who is doing interlesional RFA for the malformation. And this was a patient of venous malformation on the penile tip, and he has done interlesional RFA in this patient with good efficacy. And this is a short video, I'll just fast forward it. And it has shown good efficacy. So, this is one of the option you can try. And then we will take opinion from Dr. Rajiv Ray, maybe initially. Rajiv, sir?
Yeah. In this case, that photograph, can I see that photograph?
Yes, I'll go back to that.
In this case, I will advise radio frequency ablation because this in this tip of the penis, the glands, the vasculature is it will be vasculature will be very high. So there will be every chance of bleeding. And so with the help of a tourniquet, we can put a tourniquet. Generally, we do hypospadias surgery with application of tourniquet for about 20 minutes. It's safe. So after application of a tourniquet here, we can do radio frequency ablation.
Right.
And if, as you have said, that you can use topical sacrolimus also. But I don't have any experience with that topical
Right.
therapy.
Yes,
But
sir.
I would directly go for a radio frequency ablation, and that will be safe.
Right, sir. Dr. Suman, anything to add?
Yeah, look like predominantly venous malformation, ma'am. So I think surgical options are better. I think
Right.
I will take a higher opinion, maybe either that can be tackled to that. Ultrasound RFA, actually, ma'am, we do here also, but it is a blind procedure. So in areas where a lot of important structures are
Right.
utilized there, so I will avoid in this area whatever I
Correct.
do.
Possible, right. Dr. Akash, anything to add?
No, ma'am. One thing that sir also said, topical sirolimus may be something that can be tried because if the, oral has been given and topical may add to the results. But
Right.
again, surgical intervention seems a better option here.
How many months of oral therapy you have given, Jareen?
Now on the 4th month, ma'am. 3 months
This
are
I
complete.
have learned recently that at least 9 months it take for sirolimus to show clinically apparent response to lesion. So maybe some few more months you may try. And topical sirolimus we were using in angiofibroma, so we are used to give it. So once it has reduced to a significant size, then probably we may continue it, because this we know that recurrence, like Dr. Rahul sir said, for how many years the patient is using sirolimus, so you can't stop it. You may go to some kind of maintenance treatment, and may go to
Also,
topical.
agree with Dr. Rajiv.
Yes, sir.
That I mean, alone medical therapy may be insufficient in
Right, sir.
Jarine's case. So you may ultimately uh, should be doing whether it is RF, intralesional or otherwise. And other thing is that if you don't treat, the chances that proportionately the size of the organ may also grow because of the increased flow, and then it may even be more deforming and more difficult to treat later on. So
Right,
I think treatment will be necessary in this patient with RF
right.
or the therapy as deemed appropriate by the vascular surgeon or
Yes,
pediatric.
yes. Right. I think I'll go to my last questions before we end this panel discussion. Rahul sir showed in his PPT dermoscopic severity analysis. So Akash, are you also doing dermoscopy in hemangioma and capillary malformations?
Yes, ma'am. So, ma'am, like dermoscopy, if I'll go for hemangiomas per se, so it helps to gauge the depth. One thing. Second is response to therapy. So, in hemangiomas, we will see red-blue lacunae, and along with that, we may see the bright red background. And this is, ma'am, I think, this is for the hemangioma. So, you will see the lacunae, the bright red lacunae, and
Right,
when they are under treatment, you see the white regression areas. So
right,
treatment with propranolol or self-regression will show the whitish areas. So that signifies a response to therapy. And
right,
coming to port wine stain, so in that lacunae are absent. So that is one of the major differences. So you will see a homogeneous background and the linear irregular vessels.
right,
Again, in those patients, when you give therapy, for example, if pulse diode laser is being given, whitish structureless areas signify the response to therapy. So that helps to, gauge the response to therapy as well as in diagnosis from other differentials in each case, infantile hemangioma and Port Weinstein.
right. And confirmation, it may look like that how after 15 years of your clinical experience, how are you not able to differentiate hemangioma and vascular tumor malformation? But that happens often now and then dermoscopy does help if you are aware of the patterns. And sometime like this patient capillary malformation with underlying AVM, we read the report and the findings were something which were described, and it was shown that if there's a brown background, you should look for underlying AV malformation. So it may also help in that sense. Stewart Bluford, of course, we have reported two
Yes,
cases.
ma'am.
So in those cases also, dermoscopy does help. So I think we have reached to end of our panel discussion. Any final point, Malakar sir, before we end it?
Few
Yes,
queries, I think.
there's one thing that I should like to add about the
Right,
dermoscopy. It's
right,
important if you are seeing a very early lesion
right,
or
sir.
if you are encountering a lesion that is infantile hemangioma which is arrested,
Right, sir.
the
Right,
minimal growth and the arrested form. In that stage, it might be difficult to differentiate between infantile hemangioma and a capillary venous malformation.
correct, sir.
At
Correct,
that time, dermoscopy will really.
correct,
It
sir.
is not only the lacunae but the septa in between which helps
Right,
to differentiate.
right, sir. Thank you, sir.
Ma'am, and also one more thing, like Castleberg merit, there's one finding of hemorrhagic spot. So if you're getting
Okay,
those things, so that can signify uh, conversion to a Castleberg merit phenomenon. So that is something
oh,
that
right,
we can
right,
keep in mind. Yeah.
correct. Suman, you were saying something?
Ma'am, there are few queries from the questions there.
Acha, I'll just go
Okay.
through. I'll go to the chat box. Can you please read out, because I'm trying to go to chat
Yes,
box here.
ma'am. So first was ki sirolimus trade name and dosing that sir has Rahul sir already responded 0.8
Right,
mg per
right.
square.
Meters square.
What is the per dose actually? Then we can increase OD than BD. The
Right.
topical sirolimus dose, that was one query, ma'am.
Right. So 0.1%. So we are formulating it in the Vaseline petrolatum jelly, the tablet, and 0.1% of sirolimus we are preparing locally. If you can talk to some pharma department of pharmacology, they help you generally.
Yeah. And investigation before sirolimus.
Right, that we showed usually during this sirolimus level. Now we are not doing, but routine investigation. Viral markers are also recommended that you should do, and I think that's all. These are they have also said immunization test, but that we are not doing. But at least fasting lipid profile, coagulation profile, routine blood test, and that's all we are doing. Any other question, Suman?
Which company and tablet strength, something
That
else?
can be seen online, or there are quite a few companies.
Yeah,
Right.
Not many, but quite a few.
Right.
follow up test, like how to monitor.
So
So
this the other
Yes,
photo is showing. Once the treatment has started, following tests need to be done. So sirolimus level we discussed. Not now it's
not
optional.
required, yeah.
Urea electrolyte, liver function, full blood count, clotting profile, and fasting cholesterol. They say initially you do it monthly for initial 3 months and then do it at increased frequency.
Right. That's it.
Right. Rajiv Racer, anything to add sir, before we close our session?
No, it's already all everything has been covered nicely.
Right. Sir. Thank you, sir. Mahajan sir.
yeah, thank you.
Right.
We
Sir.
should, we should close.
So thank you all for your patience hearing, and we will close our session. Thank you.
Thank you. Thank you.
Yeah. Thank you, ma'am, and all the panelists for a wonderful discussion. I think we have about 80 participants at 10:30, which speaks a lot about how interesting it was. Now, to conclude, I call upon Dr. Rahul Mahajan, sir, to give the vote of thanks.
And thank you, Sahana. So again, as you said, so I must thank. I begin by thanking our ISPD President, Dr. Jacob Thomas, and our immediate past President, Dr. Sandeepan Dhar, sir, for giving us a platform to discuss the academics pertaining to pediatric dermatology, and all my fellow faculty, and Dr. Rajiv Ray sir, and Dr. Neetu, and all the panelists also, and all my colleagues in the ISPD Academy, especially Dr. Ram and all other colleagues, and our comparer of the session, Dr. Sahana, who conducted the session to perfection, and our audiovisual team, especially Tapas, and everyone, and especially our listeners who stayed up for so late in the night also to attend the discussions. So thank you all. With this, I conclude the today's webinar. Thank you.
Good night.
Good night, everyone.